Okay, we are live. Welcome to the Akkad and Coco Report. Unfortunately, Dr. Akkad cannot make it this fine evening, but we do have the pleasure of having Dr. Kirtane on. Dr. Kirtane is one of the preeminent clinical trialists, I would say, in the world. He works out of New York, and we're going to have him. We're going to start off by having him tell us a little bit about himself. Ajay, how did you get to where you are? Can you give us a little brief path of how you made it to where you are right now?
Sure, absolutely. First of all, thanks for having me.
Yeah, of course.
Second, as you know, it's actually pronounced Kirtane.
Oh, Kirtane, sorry.
As Indians, it's actually, I'll tell the brief story, but, I went by AJ for about, I'd say 10 years of my life. And the problem is you can't really change it to Ajay, even though my mom wanted me to pronounce it as Ajay, until the only day you can do it is the first day of school, because the rest of the year the teacher calls you and you're not going to have to do that. So 5th grade, I mustered up the energy, and basically first day of school, he said AJ, and I said, actually, it's Ajay. And 25 other kids said, no, it's not. So, there you go. And so then you go through, so I got to Ajay through high school, and then beyond that, it later became Ajay. But, how I got to where I am, first of all, you're too kind in terms of your introduction for me. There are a lot of great clinical trialists out there, and I'm fortunate to work with some of them, and I'm trying to get to that point, but it's slowly happening. But basically, I guess I was an Indian person, never really wanted to go into medicine because that was the Indian thing to do. You either did medicine or engineering. Then I was going to major in philosophy or do something else like that. And then in college, somehow my dad convinced me one sophomore, or actually freshman year, that organic chemistry would keep my options open. And so I was coerced into taking organic chemistry. I returned home from the weekend with a new pair of basketball shoes. My friends think I was bribed. And basically ended up taking organic chemistry. I loved it, and then was going to do molecular biology, and realized that being in a lab was going to be too boring. I wanted to talk to people, and I ended up in medicine. So that's how that went. And then beyond that, I was just trained at a bunch of different places, fortunate to meet people at all of those places who would want to work with me, and tried to work hard, got into some places I wanted to, didn't get into other places I wanted to, and that motivated me more. And so then ended up ultimately at Columbia about 11 or 12 years ago.
Fantastic, Ajay. You're very humble. I'll have to. So your path is incredibly impressive. You went to Princeton for undergrad, correct?
Correct.
And then
New Jersey boy, staying local.
Okay, and then so and then you went from there. You went to a little known place called UCSF.
Yeah, and so I met my wife and I were kind of long distance. She was at Williams, I was at Princeton. Then she was at NYU for law school, and I was at Columbia. And we were in the city pretty close to our families at home because they're both from northern Jersey. And luckily, she graduated law school the same year that I was graduating medical school. And so we were looking around, and she had to accept law firm offers before the match. So we were pretty much resigned to be in New York, but fortunately for me, she's super smart, and so all her firms essentially agreed to extend her offers until the match. So she took one in Boston, one in San Francisco, one in New York, and then we ultimately matched it in California. We really wanted to go out there, which was awesome, and then she ended up taking a job out there and basically supporting us during my residency, which was great.
Wow, quite a power couple. Very, very impressive. So you went to UCSF, and you did your internal medicine there. You were a chief resident there, and from there you did your cardiology fellowship in the at Beth Israel, correct?
That's correct. So Mike Gibson and I met in UCSF, and basically he had left to be at the BI and work at the Timmy Group, and I was looking to come back east for several reasons. Family was one of them. We had my daughter when I was out there. Second was the fact that there are a lot of cath labs in the Bay Area. I think when I was at that time, there was 180 cath labs in that area. So nobody was really high volume. And as an interventionalist, you do need some degree of procedural expertise. you know. So then I came out east and basically did cardiology fellowship at the BI, continued to work with Mike and the Timmy folks, and then basically did 4 years there.
Great. And then from there you did and then it didn't end there, I guess, or I guess at the same time, did you also got a master's of science in clinical epidemiology, correct?
Yeah, so it's an interesting story, but I guess it's enough time has passed that I can come clean with this. But we've blatantly violated COCATs. So, I think it's actually a good learning lesson that I tell a lot of the trainees now, in the sense that I was really focused on research. I actually had wanted to go to Brigham, and they didn't take me. And so I vowed that I was going to publish more than any of the other Timmy guys or any of the other Brigham fellows, because that's how I was going to show them that they really ought to have taken me. And this is around the time right after the Deaconess merged with the BI. And so it was unclear whether they were going to remain solvent, what was going to happen. I even called Mike and Mark Josephson before I started. And I said, like, is the hospital going to be there when I show up? You can imagine like how that call must have felt for them, like a trainee peon about to show up and is like asking how the hospital's going to be there. But anyway, I had a good relationship with Mike. And so I got there, I published a lot, but as a result, like, I didn't do the full well-rounded rotations that we really should have. So at the time, I didn't do like a single TEE. Structural heart disease on the interventional side was basically mitral valvuloplasty. Nothing else existed. So for me, why would I need to learn TE? What's the big deal? And it shows you, I think, after the fact that really, you can never really predict what's going to happen, and I regret it. And so I've kind of had to learn it on the fly since then. I think it's a good lesson about over specialization too early, and something I try to tell my kids.
Oh, that's a great thing. So you get so focused, and you kind of get blinders on in terms of. I certainly feel the same way. That I always think at the time I felt it was this quite a meandering course, but you just don't know. You just don't have a good sense of what's going to be important, and so it's just so important to have a very broad base of knowledge as you kind of build forward and build that foundation. But yeah, that's a very so. So for those who don't know, Princeton is an elite undergrad school. The UCSF is probably one of the top 5 medicine programs. BI is one of the Harvard programs, correct?
It is.
And then of course you also did a clinical epidemiology from Harvard as well. And your specific interests are you'd say structural structural interventions, interventional cardiology, as well as clinical trial methodology. Would that be relatively accurate?
No, so actually I'm more of a coronary and endovascular person. I do publications, and I'm sort of involved with the ACC's TVT registry. But
I see.
one of the things but people definitely have asked me that before, and I think one of the reasons why is because I've done academic work in the structural heart space. But what was really nice for me coming to Columbia was that one of my co-residents, Sushil Kodali, who many know in the structural heart space, he and I were interns together in residence at UCSF. And he had then, through a somewhat circuitous route, but actually it's a great story if you ask him to tell it sometime. Actually, we had our CRF Fellows course, we have him tell the story. But he ended up at Columbia. They did not want to take him at Lenox Hill when Jeff, Marty, and those guys were there. He ended up at Columbia, and then they left Lenox Hill and joined Columbia, and he was the only interventional fellow there for that whole group. But he was there, and he had a keen interest in structural heart disease even before it was a field. And so when I got there, there's nothing better than working as a junior attending with your buddy who you know for a long time. You each have each other's back. You're doing late cases at night. And he was interested in structural, and I was interested in coronary and peripheral. And so since that time, we've basically had that division, but there's no competition because we liked each other since interns and residents. And I think that synergy has helped us, at least in the mid-level portion of our program, really grow. So it's a nice story, and it ultimately gets to sort of when you're at a place, you always want to make sure that the people you're there with are people you like and can get along with. I tell all the residents and fellows this, and for me, it's been like that from day one.
Yeah, wonderful. So we'll get right into it. I asked you here to chat about the CoOp trial. The CoOp trial is a trial on the MitraClip, which is essentially a clip that's used over the mitral valve in cases of severe mitral regurgitation. And the CoOp trial, fair to say, was the biggest news. Probably is the biggest news of the last month in interventional cardiology, because it was such a stunningly positive trial. There was, it came on the heels of another trial that was a negative trial, which was the Mitra FFR trial. Is that correct? Am I getting that?
Mitra FR. Yep.
Mitra
There's so
FR
much talk about FFR that one might add the extra F.
So just before we get into some really interesting questions, can you just give me your sense of what you thought of the CoOp trial?
Yeah, for sure. And just for the audience's sake, again, I don't do structural heart procedures, so I don't put in MitraClips. I've certainly referred people for them. I've taken care of patients that have had them. And also from the standpoint of the trial conduct, although, I'm an employee of Columbia, I do work with CRF, which was involved in the clinical events committee, but certainly I wasn't involved in the trial at all. And the only way I know about it is through, the types of patients that were coming through Columbia that we were talking about with the trial, and then being sort of peripherally involved. And obviously Greg Stone is in our group as well. I think that the tough thing about mitral disease is that it's complicated, right? I mean, the thing about it is there's a bunch of different heterogeneous mechanisms by which you can get mitral regurgitation. We tend to divide them into degenerative and functional, degenerative being disease of the valves and or apparatus, and functional being largely a problem because of heart failure. But even functional, there's the ischemic functional, there's the non-ischemic functionals. So it's kind of complicated. And one of the things from listening to folks like Sushil and Marty Leon and others who think about this like every single day and night is that really there's a whole bunch of different ways that mitral disease can manifest itself. And just from clinically taking care of these patients, as you know, when you take care of them, you don't know if the mitral issue is the primary issue, the secondary issue, or anything like that. So for me, this was interesting. It had been going on for a while. I think many know that CoOp trial started before Abbott even had MitraClip. I think it was with eValve first. And the other thing too, just to know, apparently some of the folks, I only learned this after the trial came out, at Columbia were involved in the original design of the device. Mehmet Oz, for instance, was involved in the device. I certainly have nothing to do with that. But anyway, so this procedure, the MitraClip, was basically to try to emulate a surgical procedure that, if you talk to surgeons, is not something that they would use generally to treat mitral regurg unless the patient is crashing. They'll just throw in the alveoli stitch, if you will, and that can essentially, by cinching the leaflets together, reduce your regurgitant orifice and can help. And so MitraClip was designed to do that. The difference, though, is it's not an open surgery. It's less invasive and easier to do. So that's kind of where that came from. And we knew that it was reasonably effective at treating patients that were too high risk for surgery that had degenerative valve disease. And that's kind of where it's approved right now. And we're sticklers at Columbia. Becky Hahn, who's our head echo person, literally will not allow a functional MR case to get a MitraClip outside of CoOp. She won't allow it. It has to have degenerative disease. And that's different from other places where people will sort of, outside the U.S. or even in the U.S., people be a little bit more lax for patients that have bad MR and have some functional or ischemic components. So anyway, so we basically were not doing functionals. And this issue of whether treating the mitral valve could improve your heart failure symptoms, improve your hospitalizations and other endpoints was one that seemed interesting to study. And you, by the way, cut me off if I'm talking too much, but the final thing I was going to say is that it's almost interesting if you sort of took the survey of the pulse of interventionalists with this trial. Initially, there was excitement. Then it was very hard to enroll. So then people were like, there's no way this is going to work. Then, it was actually really down. Then when it was reported that it was going to be reported at TCT, there was a little bit more enthusiasm. Then Mitra FR comes out. People are like, it's not going to work. And then all of a sudden the trial is really positive. So it just tells you a lot about human nature.
Yeah. So just to get some of the detail, just to clarify some of the details. These were patients that had some type of cardiomyopathy, correct? EFs were all less than 50%. They had severe MR, and they were all, again, we use a lot of terms interchangeably, so just pin it down. They all had secondary MR. And this was, and that was at the judge, that was based on the judgment of the I guess of the team taking care of the patient. That this was not primary MR, meaning these weren't people that had flail leaflets, correct? Or what about infarct related MR, meaning these restricted posterior leaflets? Is that also was that considered?
So I haven't actually seen those data reported out
Okay.
that way. I would suspect that it's a combination of ischemic, non-ischemics. But the issue, as you know, clinically, is that there are a lot of people that have coronary disease where you don't know if the MR is truly ischemic or not. And sometimes what we do is we empirically revascularize them. Sometimes the MR gets better, but at the same time we're adjusting their diuretics and they're adjusting their ARBs. So it's tough to sort those things out.
Yeah. So so I'll say that the point, the point is that the team, looked closely and these were all patients that they felt, after going through whatever, maybe the initial suspicion was ischemic MR, they had revascularization, they still have a lot of MR, they still are symptomatic, and they're like, all right, and now folks look at the anatomy, think this person is maybe a candidate, and gets enrolled in the trial. Also, these also were patients that had to be turned down, correct, by a cardiothoracic surgeon.
They were deemed too high risk for surgery. I think some of the history behind that is that initially when the device was approved, it was approved as for degenerative patients that had very high surgical risk. And so in that vein, some of the folks at the FDA at the time, my understanding is, felt that these people either had to be randomized against surgery, which was not going to happen because, as we now know, that doesn't work and it's too high risk, or they had to be deemed too high risk for surgery. The truth of the matter is very few people like this actually get operated on, because the risks are prohibitive. But that having been said, there did have to be an assessment that it was very high risk, that was high risk for surgery.
Right. All right. Great. So these were folks that had, what's called secondary MR, which is what we think happens when classically, perhaps we can say, happens when the annulus of that mitral valve starts to dilate out and you start to get leakage. You can start to get a significant amount of leakage across the mitral valve, and these patients can become incredibly symptomatic with many different hospitalizations for heart failure, and then eventual, downward progression in terms of how they do. Now this trial was very positive, and the earlier trial was not, the MITRA-FR trial. So CoOp was super positive, MITRA-FR was not. Can you talk about why that may be?
Yeah, and I think that this is going to be a subject of debate for quite some time. There's a lot of differences. There's differences that range from sample size. CoOpt is significantly bigger. There's length of follow-up. MITRA-FR 1 year, CoOpt out to 2 years. And by the way, some of the mortality manifestations only emerged between year 1 and 2. So perhaps that had something to do with it. I honestly think the biggest thing about it was really the degree to which the CoOpt patients were carefully selected and optimally managed going into the trial. As I mentioned before, the trial was really slow to enroll. And the reason for that is because people would come in, they'd get screened, and people would say, hey, let's put this patient in the trial. They have heart failure and they have severe MR. And then the idea, and by the way, the genesis of this was through the FDA. As I mentioned, they had to be high risk for surgery, but it almost turned into a heart failure trial because there was a mandate that these people had to be aggressively managed in a heart failure type setting. Now, there are not a ton of heart failure specialists in the United States. I think the estimate I heard recently is like 1,000, but they really had to be aggressively managed. And you and I both know that patients come in with heart failure, they could have severe MR, but yet we treat them and then the MR gets better. And this would happen a lot. And not just at our site, but other sites too.
Right. That's such a key point, and that was one of my big questions after the MITRA-FR trial. Is like, man, this is going to be a really, really tough trial to show benefit in, because the MR that we're talking about here, that secondary, is so dynamic. You change systolic blood pressure. I mean, how many times have I taken a patient to a TE who's got a ton of MR on a transthoracic echo in the office with a systolic blood pressure of 130 or 140, with propofol and with a TE probe down, suddenly they have like a wisp of MR, and you look up and their systolic pressure is, 105, and they're breathing 8 times a minute or whatnot. So yeah, that was my initial thought after MITRA-FR came. I was thinking that this is going to be a real challenge to kind of exclude those patients. I mean, you really have to be incredibly meticulous, and perhaps that is kind of how the CoOp folks kind of found that sweet spot. Meaning, these were all patients that were super well treated with afterload agents, diuretics, etc. And only if they had persistent MR beyond that did they go to get the did they go to get the MitraClip. The results are incredibly impressive. In the device group, I'm forgetting now, I think it's 2 years, right? The trial. The device group had 35% heart failure within 2 years, and the control group 67% were admitted for heart failure within those 2 years. So a super impressive trial. Some questions that come up. We talked about how important the role of patient selection here was. Now, these folks did have a data safety monitoring board, correct?
Correct.
Any concern about the fact that, when you look at the survival curves, look at the Kaplan-Meier curves for whether it be for heart failure, we'll say, they separate very quickly. This is not something that took a while to, took 6 months, 9 months, 12 months to separate. Very early on, it seems clear that folks are doing really well from that standpoint. Are you and eventually, and when you look at death as an endpoint as well, there was a pretty significant difference between the two groups at 2 years as well. Those curves took, as expected, a little longer to separate out. Any qualms about continuing to run a trial when there's this much of a difference seen?
No, not for me personally. And I think but the point is a good one. And I'm glad you asked the question, because it's great to sort of say, oh, the trial was amazing and everybody pat each other on the back, but the hard questions need to be asked too. And so this is one of them. I think personally that the fact that the mortality curves didn't separate from year 1 to 2 is probably the reason why it wasn't stopped. Because as a DSMB, heart failure hospitalizations, you could argue they're not good for the patient, they're not good for the system, but as long as patients aren't being harmed in terms of endpoints such as death or going on for LVADs, transplant, you could argue to continue the trial. And what people don't understand that much about clinical trials, so the sort of casual observer, is it's not like all 600 plus patients start at day
Right.
one.
Yeah.
And they all finish at the end. What happens is they get enrolled sequentially, and you don't really have that 1 to 2 year follow-up on all the patients until really the end of the trial. So I think in real time, if you played out the scenario, what likely happened is, yes, the DSMB saw the heart failure hospitalizations, but they did not see a difference probably in terms of mortality. And so as a result, they continued enrollment. And it always happens this way, that when you have a trial that's this positive like this with a mortality signal, you sort of say to yourself, thank God they didn't stop the trial, because we've seen the opposite, where trials are stopped early for a positive efficacy endpoint. You mentioned the FFR before, so FAINT 2 is a classic example of this, and you sort of are like, why did they stop early? But that having been said, you understand why they did in that circumstance as well.
Right.
I personally wish they hadn't.
That's a fantastic point for the peanut gallery. I'll point out that even though this is a 2 year, this is a 2 year trial, that there was of the 600 patients that were randomized that started out, they only have follow up data actually on 200 of the patients. So only a third of the patients is there. I think is there data on it at 2 years. So that's a perfectly reasonable point. What what about when you're doing when you're involved in the trial? And I know you weren't. I mean, you referred patients, and I know you weren't doing this yourself. But I imagine, given these impressive numbers, that the hemodynamics here had to be improving markedly after the device was placed.
Yeah, and I think some of it is that they just don't decline as precipitously as they do in the other arm. Some of the fascinating things that I saw looking at this was like if you look at 6-minute walk distance and times like that, it's not that they improve that much in the
Mm-hmm.
clip arm. It's just that in the control arm, they just get much, much worse. And the clip arm, they basically forestall any further decline. So, I mean, I think that presumably what's happening is that you are getting, coaptation of the leaflets, you reduce the MR, your ventricle can shrink further, and then you can tolerate, medicines and that sort of thing better. I heard someone mention a TCT. I'd have to look at the data myself to see that if you look at the medical therapy adherence, and one of the important things in any clinical trial that's not blinded is you want to make sure that the two groups got treated relatively similarly with medications. And I think, if I'm not mistaken, there was or someone told me that there was a slight greater usage of things like ACE inhibitors or ARBs in the clip arm. And one of the reasons that you might presume that occurred, provided you don't just say that, it was gamed and it was,
Right.
because it was unblinded, was that they actually are able to tolerate these medicines a
Right.
little bit better because they have better forward flow and the hemodynamics are getting better. So I think a lot of those types of analyses and what the echo parameters were, all of that needs to be elucidated, and I'm sure time will allow that to occur.
Did you? Are you aware from your colleagues who are doing this that I mean, I'm sure they're doing this with. I mean, maybe they're not. Are they doing this with PA catheters in with right heart? Are they doing it? With a.
Not always. Not
Okay.
always. No, not always, but I'll tell you, in my own experience, on the degenerative side, or patients that have flail leaflets, and exactly like you mentioned, you take them to a TE and they're under sedation, they don't have anything, and then they're back in the CCU and they get anxious, and bang, they're in flash pulmonary edema. These types of patients that we have treated. Again, it's anecdotal in a sense, but this was for an approved indication. I mean, it basically stops. These flash pulmonary episodes, edema episodes stop. You can't then induce this dynamic MR and the increase in the V wave on the wedge tracing and that sort of thing. As you know, we're pretty big proponents of right heart catheterization. So it is a real issue, and it's a real thing that can get better with this therapy.
Right. So it gets to my next question about the appropriateness of surrogates. Right. So we hear a lot of folks poo-poo surrogates that don't matter to patients, and clearly, you can say if you're a hardliner, right, you can say that patients don't care about their wedge. But in reality, we know that patients do care about their wedge. They don't, because a patient that walks around with a wedge of 26 is markedly different than a patient that walks around with a wedge of 12. Was it ever? Do you think it would be reasonable? Is that in this particular case a reasonable surrogate to follow?
I think it is, and we have an active CardioMEMS program. We don't use it for everybody. We use it for people with recurrent heart failure hospitalizations and having difficulty managing them. But yeah, you can follow CardioMEMS. You can't even follow the wedge. You follow the PAD.
Right.
But it's quite effective in our institution. I mean, we have, the rate of rehospitalizations for these people that were coming in all the time has dramatically been reduced. The challenge with it, though, is the following, and it's sometimes these surrogate endpoints like MI, you can argue this little troponin leak. Is that really that clinically significant or not? And is that the same thing as somebody who has another MI that's enormous with a big Q wave? The other aspect is that there are other things that can contribute to the wedge. So if you, for instance, compare an optimally diuresed patient with a MitraClip versus an optimally diuresed patient without the MitraClip, both are going to have a lower wedge. And so some of these surrogates, when in an unblinded trial, are more subject to those types of biases. And so I think that's why, for the purposes of good clinical science and good clinical trials, you need to have multiple endpoints that include surrogates, that don't include surrogates, and obviously hard endpoints like mortality those are hard to argue with.
Yeah, yeah. And I think you bring up a great point about the dynamic nature of MR here and how important it is, and that these folks may have, may have wedges that are maybe around the same when they're when they're sedated in the cath lab, but it's this notion that perhaps the mitral clip may be reducing the MR that you get with exertion or with stress or whatnot that sends them into these these flash pulmonary that sends them that causes them to have flash pulmonary edema. So that's a very good point. If you I guess, do you feel like being a clinical trialist and a methodologist, do you feel like you're in part driven to answer to your peers? Meaning, suppose you were in a bubble where you didn't have to answer to, say, I don't know, oncologists in Oregon. Would you do anything different? Would you be more aggressive or not as careful about, say, hard clinical endpoints? Would you end trials sooner? Would certain surrogates be more acceptable? I mean, if you had your way without having to answer to, say, folks that aren't content matter experts, if you will.
Yeah, no, I mean, to me, I think at the end of the day, and I think you and I probably see things very similar this way, but I don't. The only people that I feel like I need to answer to are the patients, because you want to, as a clinician, be able to make a evidence-based decision, but with the best available evidence that you have on hand and can make, given the constraints there are to good evidence-based medicine. And there's certain things, I mean, the one reason that CoOp could be done is because this device was not approved for functional MR at the time.
Right.
And, and so I actually, to be perfectly honest with you, I'm very open and forthcoming about limitations in the evidence base. For instance, on the coronary stenting side, I don't know if you know this, but I was the one who told Vinay Prasad that Orbita existed. And this happened on Twitter
right.
A while ago. And so, and I was very interested in the trial from the beginning because I knew that we hadn't had a trial like that. But the point is that I think that there's a big difference as a clinician between adopting a stickler, I need randomized evidence for every single thing, versus understanding that sometimes it's very hard to do a trial with devices that are already approved for specific indications, because you end up with all kinds of selection bias and that sort of thing. And so at the end of the day, when you're designing a trial, you try to do the best you possibly can. The ischemia investigators, they try to do a great trial, but the challenge with that from the get-go is that people have to be willing to randomize in the trial. And it's hard to do that when conventional wisdom, whether it's actually wise or foolish, tells you you need to do X with the patient, and then you're basically trying to reverse that entire thing. So I think it becomes hard to sort that out. And sometimes, studies that are negative because of the constraints that are placed in and the way they're designed, I think actually can do worse things for patients than studies that are not done at all.
Yeah. It leads us down. A tough road. It leads us down this road of saying, all right, we should be sticklers. As you're saying, you had somebody there who would not allow mitral clip placement without enrollment in the trial, correct? And you need that kind. You almost need clinicians' hands to be tied early on. That's one school of thought. Clinicians' hands to be tied early on. You have to participate in trial just so that you can show efficacy, and then if once you show that convincingly, then you kind of end questions for all eternity, and because now something isn't established or isn't conventional wisdom because of a bunch of anecdotes or experiences. Is that that's generally your thoughts on the matter.
You know, I would hope so, but the problem is that it actually doesn't end things, because
Yeah.
then other things come along, and then people say, well, that trial was done a really long time ago, so we don't really want to believe the results. And I've heard people say this about left main disease.
Right.
I mean, there are randomized trials showing you save lives with revascularization of left main disease through surgery.
Right.
And that people are, well, you know, but that was done before aspirins and statins and beta blockers, and so that data should be thrown out. So, you know, look, I get it. I don't want to whine about it, but the problem is that when you're in a situation where something is in practice and you haven't done those trials, then you have to adopt your practical I treat patients hat. You can't be a particular clinical trialist at that point. You need to sort of say, well, okay, now it's going to be really hard to go back and reinvent the wheel and do trials in that way. And so that's why Orbita is a unique trial, and that's why I was in support of doing the trial, because they could actually do it in the UK. But I don't think it'd be a very easy trial to do here in the U.S.
Yeah. No, and it just, you know, I always get nervous when you tie the hands of clinicians, because once you're tying the hands of clinicians, then, you know, are you necessarily doing the best thing for patients? But these are
right.
Obviously good points on either. It's a good, healthy debate that we should definitely continue. Other questions. Do you think this is scalable? Do you think the results from CoOp, do you think this is something that's going to something that is easily scalable?
Well, it better be, right? I mean, I think that what nobody wants, I mean, me certainly, because you know, I'm all about patients that are not being treated with therapies they ought to be treated with, that, you know, the underuse side of things. But I really don't like overuse either. I think it's an embarrassment to our field. It's what gives, you know, a lot of energy to people that would critique potentially take away therapies that would. So I think it has to be done in a thoughtful way. I think these people don't need to be seen by a heart failure specialist, but if they have one, it would be great to do it. But I'm sure that when this gets reimbursed, forget beyond the approval, it's going to have to be, you have to document that you actually tried with medicines and you just didn't throw a clip in. The other thing about, I mean, it's not throwing a clip in, obviously it's a transeptal, but the mitral clip is actually a pretty safe procedure. Right. So I think that we just have to be tempered about it. We have to understand the difference between this trial and mitral FR, where patients weren't optimally managed, and recognize the fact that in a randomized trial, if you don't do it the right way, there's no benefit.
Yeah, and my big concern, I just see this over and over again, you know, and everyone talks about this, and we know this happens, that you know, a new procedure comes out, a new therapy comes out, it's shown to be very effective in this group of patients, and then it gets scaled because of, you know, incentives that we all talk about as well, to folks that, you know, have lesser and lesser benefit, right? And coronary stents, it's entirely possible that the difference between the ACME trial, which had a really large benefit, and Orbita, is not just that one was a sham and one wasn't, but that the patient population that you're testing, you know, VA patients in the early 1980s, the patients being taken to the cath lab then are much different than the patients now that are, you know, the average patient now that ends up on the cath lab for stable angina. And my massive concern is the same thing's going to happen, because there's such a massive incentive to build these type of programs, because there's such big money makers. And I don't know, I have no idea how one goes about tempering that, meaning, any ideas on how we can break the cycle that seems to happen over and over and over again?
Well, you know, I don't adopt as defeatist an attitude, because, for instance, if you look at what happened with TAVR, it's a pretty reasonable approach, and the surgeons are involved. We talk about the quote unquote heart team. It actually exists, and not because CMS mandated it, but that's fine. There's nothing wrong with that. And in fact, if you need to do that, then go for it. And I think that's what CMS will do. I think that works. The other thing too is that, one of the reasons why stenting, I think, achieved the status it did is because it's really straightforward to do. The other thing is that everybody always talks about harm. Actually, there's very little, no randomized trial has ever shown harm over medical therapy. And whereas this is different, and this also requires anesthesia, it requires TEEs, it requires a significant amount of time in a hybrid. So there are logistical challenges to this that actually are probable natural roadblocks, and that may be a good thing as well. So I think that we've seen it before, we're wise to it, and it really is on us and societies to make sure we do it right.
Yeah, yeah. No, you cut out briefly, but you essentially you're saying that.
I had a good punchline. I'll say
Yeah.
it again. It's on us societies to make sure we do it right.
Yeah.
That's
All right, excellent. So we shall then try to draw down with that optimistic note that hopefully this is certainly it's a fantastic trial. There's another trial that's coming down the pike, we should say, right? It's the Reshape HF trial, I believe, that will also provide us more data and keep the conversation, keep the debate ongoing. But it certainly seems that what's been found in CoOp, suggests that there's a sweet spot of patients that would really would really benefit. So,
yeah.
But
I mean, the one thing I'll say about Reshape HF is I've heard a few things about it. I've heard that there's a very heterogeneous group of MR patients in there, some that don't even have severe MR. And the other aspect is with CoOpt having come out, I don't know what's going to happen to enrollment in that trial.
Right.
Because, and that's, by the way, also true for all the other mitral therapies that are going on here in the United States. It's kind of hard to randomize against control when you have these results. So I think the whole thing changes quite a bit as a result of this.
Fantastic point, Ajay. Thanks so much for the time. Really great. I hope we didn't take up too much of your precious time away from your wife and kids.
No, it's all right, because I was talking about my wife. I think I bought myself some more time. I mean, she's actually an amazing person. The family's great, but she doesn't work anymore. She once I started working, then she actually took it on herself to do 4 other jobs, including Board of Ed and shuttling the kids around and basically supporting me, because as you know, if you come home and you things are not great at home, it's like impossible to work. So I've been very fortunate in being able to have her for my life. So she cut me a little bit of slack tonight.
Well, wonderful. So yes, we definitely need guys like you and me. Definitely need a ton of support. No question about it. Alrighty, thanks so much, Ajay.
Thanks for having me, and hope to listen to your next one sometime soon.
Absolutely.